Hello, everyone, and welcome. I'm Nicole Sanford, the President and CEO of Aspira Women's Health. If you're not familiar with our company, we are a NASDAQ listed company that's focused on the development and commercialization of innovative solutions to diagnose gynecological disease. We believe that women of all races, ethnicities, and socioeconomic backgrounds deserve to have access to diagnostics and diagnostic tools that leverage the best science and technology available. It is a true privilege to lead Aspira and an honor to host all of you this evening. I do not want to take up too much time with opening remarks, but I do want to thank all of you for being here with us for a discussion that we need to be having every day, not just during Black History Month. Our research and the research of many others proves conclusively that historical approaches to finding and treating ovarian cancer are overdue for innovation for all women. However, as you will hear tonight from our distinguished panel, the situation is even more grim for women of color. I hope you will leave tonight inspired to push for change in our healthcare system and that you will seek out and support companies like ours that are working hard to change health outcomes for women as our advocates and maybe even as investors. I'm going to stop there and hand things over to Denise Kelly, Aspira's Market Development Manager, who is based in Georgia. Denise joined us after serving in the Air Force for more than 6 years, and she's now a rising star in our company. Today's webinar was her idea, and she, along with Victoria Haverbush, who's also on the line today, planned every detail. Denise, thank you for everything that you do every day to make all of us at Aspira proud. The floor is yours to introduce our incredible panel of thought leaders.
Wow. Thank you so much, Nicole. And thank you for sharing our mission with everyone on the line. Good evening, everyone. As Nicole mentioned, my name's Janice, and I'm going to be your moderator tonight. So before we get started, I just want to do a couple of housekeeping issues. Two things. First, this webinar is being recorded, and this recording may be used in the future by Aspira Women's Health. And second, if you have any questions as the panel is going on tonight, there's a little feature at the top of your screen that says Q&A, and you can feel free to click that button, type your question, and we'll try to get to it by the end of the presentation. So as you know, Nicole talked about our mission, and part of that mission is to offer solutions for all women. And I'm just so grateful to work for a company that not only acknowledges the challenges and the barriers that marginalized communities face, but is actively doing something to drive change. So I feel honored to be here. And we recognize at Aspira that it's not enough to research health disparities. We must take action in order to see improved outcomes. And each of us has a unique role in helping that along. So on this call, there are healthcare providers, ovarian cancer survivors, and advocates for change. So thank you for being here. Our goal tonight is that each of you with your unique roles will walk away with an understanding of what to do. So without further ado, we have a very special all-star group of panel members tonight that I'm very excited to introduce to you. So, and I'm going to start with a very special guest, Miss Kimberly Emory. Miss Emory is a 16-year ovarian cancer survivor, and she's also the president of the, yes, thank you, Dr. C. She's also the president of the Georgia Ovarian Cancer Alliance. Miss Emory uses her story and the lessons she's learned from her diagnosis and treatment of ovarian cancer to arm women in the community with the information that they need so that they feel empowered. So thank you, Miss Emory, for being here. We also have Miss Linda Goler Blount on the line. Ms. Blount is the president and the CEO of the Black Women's Health Imperative, which is a nationally recognized organization leading the health policy, education, research, and communications designed to improve healthy outcomes for Black women. So thank you for what you do. And we have Dr. Tamika Sea. Dr. C is a board certified OBGYN, and she's the owner of the Advanced Women's Care Center, which treats patients in the Atlanta area. Dr. C is a champion for closing the gap in ethnic disparity in healthcare, and she uses her treatment approach for patients and investment in agents that are driving change. And then finally, you see Victoria Haverbush on the line. Victoria is my colleague, and she's a brilliant genetic counselor, and she has a unique understanding of the role that genetics play in research and diagnosis of ovarian cancer. So now that we've gotten everyone introduced, I'd like to talk about why we're here. You know, when we were thinking through this webinar and why it's important, there are so many issues we could discuss. We could talk about maternal mortality. We could talk about preeclampsia. There are a lot of women's health issues that face ethnic disparity. So Dr. C, I'd like to ask you the first question, and I'd love to know what, in your professional opinion, what is the urgency and why should we care specifically about ovarian cancer? Because we know that the incidence rate is lower in Black women, right?
Correct.
So, yeah, can you give us some insight on that?
Sure. So ovarian cancer in general is the fifth largest cancer diagnosis, I should say, in regards to in regards to demise in women in general. So fifth leading cause for cancer death. So this is very important just for women in general. But of course, when we discuss the health disparity that we see in African American women, we are inclined to have more of that death rate when it comes to ovarian cancer diagnosis in the United States. In fact, we as African American women tend to show up with more advanced stage ovarian cancer disease processes. We tend to show up with stage 4 ovarian cancer much more likely than any of our other ethnic counterparts, particularly of Caucasian women. We tend to be about 43% of our diagnosis is going to be at stage 4, which is profound. So this is a very, very important topic that we need to discuss in general, just for women's health and just for women's health advocacy in general. But it's so important for African American women to know this information, and for clinicians to be more sensitive to this topic in regards to, you know, what is it that we need to be looking for, particularly in this ethnic population where they're so detrimentally affected by the cancer risk for ovarian cancer.
Absolutely. Wow. So that was really powerful, and thank you for laying that foundation. And I know that you mentioned Black women are often, ovarian cancer is often discovered in late stage 4. And that is, you know, that makes it really hard to have good outcomes. So, but I know, Ms. Emory, we've had conversations in the past about your path to diagnosis and what that looks like for you. So can you share with us your story, your story of detection and diagnosis and treatment and how that went for you?
So yes, Janice. So my story starts in 2005. My symptoms were the classic ovarian cancer symptoms: general abdominal discomfort, bloating, feeling full after a meal, nausea, diarrhea, constipation, frequent urination. I also had some other symptoms like indigestion, back pain, and I had all of these symptoms every single day. Sometimes the pain level would be at a 7, and sometimes it would be at a 25. And I was seeing my primary care physician at least once or twice a month, and sometimes as many as 3 times. Every time I saw my primary care physician, I would tell her, something is wrong. I can feel it. Then I would go over my symptoms with her, my abdominal pain, feeling full after meal, nausea, diarrhea, frequent urination. She would give me anti-nausea drugs, drugs for acid reflux, antibiotics. Then she would order test after test, x-rays, upper and lower GIs, colonoscopy. I had a abdominal CT scan, blood tests. And she sent me to 2 GI doctors, one of which was a white male who told me that I needed to see a psychiatrist. So me being me, I gave him a piece of my mind and a lesson in bedside manner. How dare you dismiss my pain and suggest it was all in my head? You know, as a researcher, Janice, I would go home and research my symptoms, get frustrated, second guess myself, and get sicker. And it wasn't until I attended a lunch and learn sponsored by my job in partnership with the Georgia Ovarian Cancer Alliance. And at the time, I had never heard of ovarian cancer. I listened to the speaker, and afterwards I took the symptom and risk card and returned to my desk and continued to get sicker. And one day I came in, opened my desk drawer, and there was this card. And I finally looked at the card and I checked off every single one of the symptoms and called my primary care physician and told her I needed to come in and show her this card. And when I came into her office and showed her this card, it was like a light bulb went off in her head. And she immediately called for her nurse, her referral coordinator, and set me up for a PET scan that afternoon. You know, after a year and a half of back and forth and many tests and seeing a few specialists, one of who called me crazy, I finally had something that made sense. My primary care physician and I, through divine intervention, found the world's best gynecologic oncologist. And after looking at my scans, he set me up for surgery immediately. So on March 17, 2006, I had my left ovary, fallopian tube, omentum, and appendix removed. And everything was sent off to pathology. And when I woke up from surgery with my family by my side, I was told I had stage 2C ovarian cancer. Specifically, I was diagnosed with a rare germ cell tumor called an endodermal yolk sac. And I had everything happen to me quickly, from surgery to diagnosis to chemo, all of that in less than a month. And somewhere between surgery and chemo, I had another minor surgery to put in the port. And the next few months were tough for me and everyone around me. There's nothing good I can say about chemotherapy. That napalm that they give you sucks the life out of you. But I fought this disease with everything I had. And I still lost some things along the way. A year of my life, my hair, my friendships, and my ability to have children. So overall, that is my story. From diagnosis to sitting here now in front of you, almost 17 years, NED, cancer-free.
Thank you, Ms. Emory. I don't know about you all, but I think someone's cutting onions in here. So thank you for sharing that story. You highlighted some really important things, Ms. Emory, just through your experience. And one thing that you highlighted is the fact that you were premenopausal and lost that ability along the way. I think that highlights for us that this is not just about cancer. There are so many impacts, secondary and tertiary impacts to this disease.
And it's not just the older woman's disease also. And that's one of the things that, you know, I lost my ability to have children. And within my organization, the Georgia Ovarian Cancer Alliance, we come across a myriad of ages, you know, 2 years old, 18, you know. I was in my 40s. I had waited so long to have children, and then to have that ability snatched from me, you know, was very disheartening. You know, it's what ovarian cancer is. It's the whole woman, the emotional, the physical, everything. And then to have a doctor, a white male, tell me that my pain wasn't real. I was crazy. I needed to see a psychiatrist. But me being the type of person that I am, I kept hitting, I kept going at it. I learned to advocate for myself. And that's important for a lot of women. You know, we have to advocate for ourselves. And we have to, and I was happy that I finally found a doctor who could put those puzzle pieces together and give me the diagnosis of ovarian cancer. So.
Wow. Thank you, Ms. Emory. Thank you for sharing that. It's really powerful. And, you know, in addition to the aftermath of that, you shared that you went to see several different specialists before you landed in a gynecologic oncologist office.
Exactly.
And we know that women actually the average woman takes between 6 to 18 months before she's diagnosed with ovarian cancer. And you mentioned a couple barriers to your care along the way. And one of the things that you mentioned was pain dismissal. And I know that we see that in multiple disease states. That doesn't just apply to this disease.
Right.
So Ms. Blount, can you talk to us about some of these barriers that Black women face in their access to care? And then once they get there, what are the barriers that they're facing?
Yeah, I can. And Ms. Emory, thank you so much for sharing that story. Thank you for being relentless. Thank you for not giving up. Thank you for doing your research. Thank you for being the perfect example of a patient advocate. I would say that I want us to all be able to just get the standard of care, and we shouldn't have to do all that, but sometimes we do, because there are real barriers that we face. And you faced a barrier of, first of all, not being believed, not having your symptoms taken seriously enough to act on. I mean, you got a number of tests, but to have a physician tell you, and I'm sure Dr. C must have been shaking her head to tell you that your pain is in your head. Like,
Right.
No, you wouldn't keep coming back week after week, month after month, if this was, the pain was not real. So unfortunately, that is a barrier that a lot of Black women face. Their symptoms are not taken seriously by their providers. Some have just a lack of access to quality care, even if they have insurance. And some of us are underinsured, but even those of us who have insurance, sometimes that insurance is no guarantee for quality care. Right. And we know, if you look at the NCCN guidelines, only about a third of Black women are likely to get the guideline standard of care that the NCCN says, should happen as compared to nearly 50% of white women. So we're not even likely to even if we're believed to have the doctors act on that. And we know we're less likely to have our symptoms followed up. But there's other factors. You think about what Ms. Emory had to go through. She's back and forth to doctors. That means she had time. She had to take time off from work. There were transportation. If she had had children, she would have had to arrange for child care. So there's a cost there. These are a number of barriers that can keep a Black woman in particular, but all women from care, because they look at what the toll it takes on just their daily lives, and they can't do this. And it costs money. And we look at, we talk about the difference in mortality, and sometimes doctors and providers and researchers, we know, look at these mortality rates as though, oh, that's just supposed to happen. It's, this is what happens to Black women. And, I just want people to know that, it's not because we're Black, that there's no biologic or genetic determinant for race. It's not that. It's because our cancers do get diagnosed later, but that has to do with all of these barriers we've talked about. It has to do with many providers, not all, but many not acting on our symptoms. And it also comes about because we're not offered that standard of care, and there's no real repercussion for not being offered that standard of care. But I want the listeners and the viewers to know that if you have a Black woman and a white woman, and if they have the same ovarian cancer diagnosis, same stage, same treatment, they will have the same outcome. There is nothing about being Black that would cause us to die more. And so we need to know that race is not the risk factor. It's all of these other factors that determine whether or not we'll have good outcomes, get an early diagnosis, and live to tell the story and be the inspiration that Ms. Emory is.
Wow, amazing. Thank you for what you do in that space, Ms. Blount. That's incredible. And seeing you being a champion for women in this is really empowering. And I'm grateful to be here with you. So you mentioned a few things that come up often in ovarian cancer care, and people on the line, if you are in the healthcare space, you've probably heard this before, but ovarian cancer is often called the silent killer, right? And I think most people who have true experience like you, Miss Emory, you're shaking your head because we know that ovarian cancer is speaking to us. But the connections aren't being made there, and especially in marginalized communities. Ms. Blount, you also mentioned, the survival rate and the mortality rate of some of these diseases. And Dr. Sea, you talked about how ovarian cancer is at the top of that list. And in fact, I read that Black women only survive, their 5-year survival rate for ovarian cancer is 41%.
Yes.
And so when you make that statement that there's being Black is not a risk factor, that's highlighted in this disease. So as we think about this, and this weighs heavily on us, I know all of us that work in this space, it weighs heavily on. And if you don't work in this space and you're just on the call, I'm sure you're feeling jarred or moved by this. So Dr. Sea, I would love if you could talk to us about the way you see patients in clinic every day and how you account for their diverse backgrounds when you're creating their treatment plan.
Absolutely. And thank you, Ms. Blount, for going over some of those other things that I failed to mention in regards to, the issue when it comes to Black women and ovarian cancer. And you bring up an excellent point that if everything is stratified for, diagnosis time, the cancer, stage, the cancer grade. If all women are treated with the same surgical and chemotherapeutic plans, that the actual outcomes are that Black women survive just as well as white women survive. So I think that's a very, very important point that you mentioned. And yes, that is absolutely correct. And just to touch on that a little bit more, there is this dichotomy when it comes to guideline recommended care that is being offered to Black women versus white women. And some of that is, of course, going to be possibly some patient refusal, and that kind of goes into how I try to discuss and talk with patients in regards to diagnosis, treatment, plans, post-surgical and chemotherapeutic plans with their oncologist. But some of this also is going to lay at the feet of the practitioner. And I believe, Ms. Emory definitely explained that very, very in detail in regards to her experience. So a lot of this is going to be the onus of the healthcare provider to make sure that they are not just culturally sensitive, but culturally competent to understand their patient's background, understand their patient's ethnicity, understand their religious perspective, be more cognizant of who you're seeing and not necessarily placing them in a lineup of all of the other patients that you're doing ovarian cancer screening for. There are going to be nuances. There are going to be ethnic populations that have disparate statistics when it comes to some of these cancers that we are looking for. As a gynecologist, of course, I'm screening for cervical cancer, I'm screening for ovarian cancer, uterine cancer, we're breast cancer, we're doing the whole gamut. And every one of those cancers particularly can have some sort of ethnic disparate or religious, aspect or some type of something that the patient comes in with that is their unique self, that we need to be aware of so that the patients are receiving the care that they need. And I think that is a very important factor that healthcare providers need to take home, digest, understand, and make sure that they're treating the whole patient.
Absolutely. Wow. Dr. C, I really appreciate the way that you take an individual approach to each patient. And if you would like to share an example where you've modified a treatment plan, maybe based on some sort of, ethnic information or religious information, we'd love to hear that from you.
Sure. I have two examples. One, not in an African American setting. I had I think I've told you the story before. I had a couple that was of Ashkenazi Jewish descent, and for those that are unfamiliar with the genetic makeup of this population, they tend to have very significant risk factors for certain genetic disorders, certain cancer risk factors. And particularly, I was counseling this couple in regards to childbearing. And it was very important that I knew that information about the couple, and they were actually astounded by the fact that I was aware of the difference and the nuances with that ethnic population, what genetic disease processes they were at risk for, and to make sure that they got the proper screening preconceptional wise, so that they would be, more equipped with, the possibilities when it was time for them to get pregnant. I think that's definitely one of the examples I like to kind of go to, because it's such a very niche ethnic group that, if you did not understand, and if you didn't know, and if you didn't research, and if you didn't remember your, genetics from medical school, and know that this was a patient population that you should pay attention to when it comes to embryology and development of fetus and obstetrics, then you would have missed it. So that's just a situation where I know for sure, that couple was helped because I paid attention to an ethnic nuance that they had. And I know that Victoria probably can speak a little bit more about the genetic aspects of that population a little bit more than me, because she probably deals with it a lot more than I do. However, it definitely, was one of those situations where the patient thanked me for being competent. The patient thanked me for understanding that there was a difference about them and actually going the extra mile to make sure that that difference was investigated, explored, and make sure that everything was going to be all right with them when it came time for them to have children. So that was just one example. I'm sure I probably have many other if I sit and think about it, but I think it's just very important that we have that cultural competence and know the patient population that we treat, and knowing the ins and outs. And like Ms. Blount said, this isn't just, Black women die from ovarian cancer more than white women. No, this is a very intricate, health disparity, health equity issue that we all should be invested in and should have buy-in with.
Wow, thank you. So you talked about knowing your patient population, and I think, Dr. C, a lot of women believe when they go to their annual exam that they're being screened for ovarian cancer. I know I would have assumed I was being screened for ovarian cancer
Yes.
prior to entering this industry. And so I understand, that can be a barrier in itself, but once the patient shows up, what is your obligation as a healthcare provider? Let's say I'm your patient, Dr. C, and I show up and you find a mass on ultrasound, and I have pain and bloating and look, Miss Emory, all of her symptoms. Let's say I walked in your door with those. What tools are available to me for that patient or to you as a provider, and how can those tools help us close the ethnic disparity gap? And you may tap in, Victoria, you may want to tap in here too, and just let us know what you think.
Well, I think the biggest thing is that, what research is showing and suggesting that single usage of things like CA-125 alone for screening, ovarian cancer screening, is just not apt. In fact, is not apt across the board. Multivariate index screening is what is the preferred method for ovarian cancer screening, because we know that CA-125 is just not the only ovarian cancer marker that we need to be looking at and addressing. So, something like what Aspira Women's Health has available in regards to Ova1, Ova1 plus, Overa screening, which we can talk about a little bit more. Those screening tools allow for there to be a multivariate index assay, provided, so that we can get a better understanding as to what is this patient's clinical risk assessment for ovarian cancer, and not depending solely on CA-125 when it comes to biomarker screening. Of course, Janice, if you walked into the office, you had those symptoms, of course, get the ultrasound, make sure that, if we see any of those kind of concerning features with the ovarian cysts, if there are excrescences, if there are papillations, multi-septations, a lot of the things that we're looking for to increase our suspicion that this is just a simple ovarian cyst that's going to go away over time, that would then allow for me to utilize tools like Ova1, Overa, Ova1 plus as the screening tool of choice to see whether or not this patient has any risk factor for ovarian cancer.
Okay, and would you, in your practice, would you use that in place of CA-125 alone?
I do actually use that in place of CA-125 alone, and there's a large reason, a couple of reasons why. We just discussed, that's kind of becoming more of the gold standard as far as screening tools, is to utilize a plethora of different biomarker screenings together to get more of a clinical picture for the patient. But then also too, with CA-125, there's lots of research now that is coming out suggesting that it is not the best screening tool in African American patients. And it performs poorly when it comes to helping with that early cancer screening for African American patients. So actually, thank you, Victoria. She put up the slide for us. So with this slide here, it's very important that, you know, with CA-125 alone, it has a low predictive value and concerns for missing ovarian cancer in the African American population. So as we see here, we still have a sensitivity above 50% in detecting malignancy across all categories of women, but very important that we still have a low sensitivity when it comes to that CA-125. In African American women in particular. So as we see here, the usage of CA-125 with the standard ACOG cutoff in Caucasian women has a sensitivity of about 74.4%. However, the usage of the same cutoff in African American population only showed a sensitivity of 33.3% in the detection of malignancy. So a vast, vast difference in the detection of early stage ovarian cancer in this population versus Caucasian when it comes to CA-125 alone using just the ACOG cutoff. And now you compare this data with the usage of a multivariate index assay such as Ova1 or Overa. We see that the increase in sensitivity for African American women increases to 79.2%, which is absolutely amazing when compared to just CA-125 alone. So this is definitely a clinical tool that you want to have access to in offices, simply because it outperforms CA-125 for all of the patient population. So this is why this is so important, but specifically for the African American community, since CA-125 is just not expressed the same in that patient population versus the Caucasian population.
Wow. That is, you know, if you've worked in the ovarian cancer space, you've heard of CA-125 before. And Miss Emory, can you have some experience with CA-125, right? Can you tell me about your CA-125?
So my CA-125 was completely normal. And the reason being was because I had a germ cell. So my CA-125 was always going to be normal, and it was never elevated. So that was one of the barriers, you know, I faced. We always see CA-125 as a diagnostic tool. And that was something that I thought about. Have I had a CA-125? But now, knowing what Dr. C has just explained, it opened up a whole new world for me that, you know, CA-125 was never going to diagnose my ovarian cancer, you know? So I know we've had conversations about this, Janice, about what is keeping doctors from, or what is keeping doctors tied to the CA-125 as a diagnostic tool or whatever. What, you know, maybe some of the doctors, you know, in the chat can say what is keeping them tied to this, because seeing these statistics that we on the slide is very eye-opening for an ovarian cancer advocate. When I go out to health fairs now, I want to tell women, you know, there are other diagnostic tools, Ova1, you know, not just because we're on Aspira's, you know, webinar, but because the statistics now say, you know, we should be looking at other diagnostic tools.
Absolutely.
I think there's an unlearning that has to happen, Ms. Emory. Unfortunately, you know, in training, you learn that CA-125 is that gold standard when it comes to the evaluation for ovarian cancer. And I know we've spoken before, you know, the purpose of CA-125 was not even for the actual diagnosis of ovarian cancer. It was more so utilized as a clinical tool to look at the how effective a chemotherapeutic agent was for a patient. So it's more so for following a patient's ovarian cancer, not necessarily for diagnosis. And of course, you know, for the clinicians that are on the on the line, there's a multitude of other different things that will cause your CA-125 to be elevated. Okay, right? So you can have fibroids, and you can have endometriosis, you can have an appendicitis can cause your CA-125 to be elevated. It is just the the biomarker for pelvic or peritoneal inflammation. It's not it unfortunately cannot be this end all be all diagnostic tool that we've allowed for it to be for 30, 40 years. So I think the problem is that there's an unlearning that has to happen as in the med school patient, in the med school population, right. In the residency population, so that when they do, come out into the real world and actually practice and actually see patients face to face that they are responsible for, knowing and being aware of this new data that suggests, you should be looking at multiple biomarkers as far as screening when it comes to ovarian cancer risk assessment for these patients. And also too, the caveat is, hey, guess what? This does not show up well in Black women and Hispanic women. So it just does not show up well in these set populations. So be careful about utilizing this as your end all be all. But unfortunately, you have people that have been in practice for 25, 30 years, and this is what they learn. Therefore, this is what they know. So I think having webinars like Aspira Women's Health is performing tonight, just bringing more awareness to, hey, we have some other, tools in our armamentarium now that are much more sophisticated than CA-125 alone. And, let's use them because,
the key word that you use, Dr. C, and, we've discussed this, is the unlearning of what we, and that goes for the greater community too, the ones of us who are in the advocacy space, because that's one of the diagnostic tools we tell women to have: a CA-125, a pelvic ultrasound, rectal and anal, and, pap smear, whatever we're told. So the unlearning of that, great word you use. We need to, think about doing that too.
Absolutely.
Thank you, ladies. Thank you for sharing that. And, CA-125 comes up all the time. And so, Victoria, I'd love for you to talk to us as a genetic counselor. Dr. C mentioned that it doesn't perform, CA-125 doesn't perform well in Black women, but can you talk to us about some of the maybe genetic components preventing that, or what's your perspective on this conversation?
Absolutely. I really appreciate everyone's points of this discussion. It's certainly raised a lot of really important issues that don't get a lot of attention in the healthcare space. And one of them is really this overarching truth that in terms of risk assessment, diagnostics, genetics, it's not enough just for patients to be offered, quote, the same test as another patient. They also need to be offered a test that keeps their risk in mind and keeps their physiology in mind. And so something we've seen in the genetic industry especially is that the data sets that we worked off initially were predominantly white, and that's really put in some limitations that the industry is having to overcome now to make sure that these tests are effective across all populations. And then when we think about CA-125, CA-125 was discovered in a very homogeneous population decades ago, and we've just been applying it out of context ever since. So I think this discussion brings up this really important truth that in diagnostics and risk assessment and test development, the companies, the healthcare providers, everyone has a responsibility to not just apply the same technology to every patient, but to make sure that the technology that's being applied actually works and fosters to decrease this gap that we're seeing in care. Because when we see CA-125 being used out of context as this surgical triaging tool, we know it underperforms in Black women and other women of color. That means those women have a chance for their cancer to be missed. As Dr. C said, as Ms. Emory said, as Ms. Blount said, have a longer, more complicated journey. And that doesn't do anything good for their outcomes or for the healthcare system's trust as a whole. And so I think we all need to think really deeply as providers, and also people like me who are on the company side creating these products to make sure that the technology is developed from a diverse and representative data set. So we're not dealing with these uphill battles once they're out in the wild.
Yeah, that's a great point, Victoria, and a good segue into something I want to talk about with Ms. Blount. You guys are just bringing up all kinds of things for me, and I was doing some research, Ms. Blount, and I saw something that said that Black women make up 13% of the population, but they only make up 3% in clinical trials. And so Victoria talked about how the genetic space has to accommodate Black women, but what do we do if the people researching the disease aren't even including Black women on the front end? What do we do?
Well, you raised an excellent question, and I have to think about CA 125 decades ago. I can pretty much guarantee you there were no Black women in those studies. So not only is that important that people of color, that we have a diverse representation in clinical trial participants, but also among the researchers as well. Because the thing we talk about evidence-based medicine all the time. And evidence depends on who's asking the questions and who they're asking and who's doing the analysis and maybe even who's doing the funding. And so we've got to be real sure about where the data come from. I would love in medical school if, Dr. C, if they train docs to first ask, well, where did the data come from? Who was involved in these studies? Because it does matter. We've talked about the numerous barriers already, but lack of representation in clinical trials and research matters in diagnostics and matters in therapeutics, even in screening tests, as we've seen. You just think not very long ago, COVID-19, oh, look, pulse oximeters don't work as well on people with dark skin. Dexamethasone is not as effective on African Americans with severe respiratory symptoms. Well, why? Well, who was in those studies? And so, we think about medical mistrust, and there's, these are the kinds of things that can give rise to medical mistrust. We need to get more participation in clinical trials. But again, it's important to note that mistrust is truly, a valid response. But the single greatest reason, the single most cited reason that Black women don't participate in clinical studies is because nobody asks them. So doctors make all manners of assumptions about what women will do, what they won't do. Can they afford it? Do they have the time? Will they comply with the treatment regimen? They don't even get the opportunity to participate in clinical trials, let alone be able to say no. And when we look at researchers, the percentage of physicians, Black oncologists, Black physicians, R01 funded researchers of color by NIH, those percentages, 5%, 4%, 2%, they haven't changed in 40 years. So obviously these researchers can do more than just focus on diseases that disproportionately impact people of color, but they're the ones that have a vested interest. And if that doesn't change and the participation doesn't change, then we know we're not likely to see differences in outcomes. And we know from the data that racial, ethnic, and gender congruence does make a difference in terms of improved outcomes for patients. And so we know Black women are less likely to be asked about their history, their family history, which means they're much less likely to be offered genetic counseling. The demographics of this country are changing. So in 20 years, the average adult will be something other than white. And if we don't change the way our leadership structure, the way we're conducting research, the way we're making these decisions, then we're going to have hospital systems and pharmaceutical companies and other major academic institutions where the leadership is really out of step with the patient base or the customer base or the client base. So, one of the things that we need to do is, really question, where is this data coming from? The FDA talks about needing diversity in clinical research, but they don't enforce their own guidelines. So we need to make that happen. Pharmaceutical companies and researchers also talk about having diversity, but they say, oh, it's too hard to recruit patients of color and retain them, and it's too expensive. And so all of this means, Janice, that we end up applying a body of evidence to a population that had nothing to do with its creation, and that can have deadly results. So I would just say to those who are listening that there's no such thing as the hard to reach, there's only the hardly reached. I used to work for Coca-Cola. We had no trouble reaching anybody. So if we want to reach people, we can absolutely do it.
Wow. Thank you, Ms. Blount. I love the way you laid that out. And I think that we've talked about a couple ways tonight that the healthcare community can really wrap their arms around this issue and push it forward. And I would love to hear, you know, as all of us work in healthcare, but there are people on this call who are also advocates for change and survivors of ovarian cancer. So, Ms. Emory, can you talk to us about how the community, how other women and people who just care about women and love women, from that perspective, how can we take care of women who are potentially facing a diagnosis of ovarian cancer?
So how you can help women and how I approach this, and you know, I can only talk from, you know, my perspective. I surrounded myself with women. I call these women my tribe. And I leaned heavily on these women. My organization, the Georgia Ovarian Cancer Alliance, although they came to my job and did a lunch and learn, it wasn't until after I was diagnosed that I learned about some of the programs that they had in place. We do a great program called for women who are survivors. It's called Survivors Teaching Students. And what we do is we go out to medical schools and we talk to 3rd and 4th year residents and we tell them our stories so that they can hear about ovarian cancer first instead of last. So they can hear these women's stories and it resonates with them when they're out in the field doing whatever, whether they're OBGYN, psychiatrists, dermatologists, whatever. If a woman comes to you and, you know, you've heard this story before, you know, like my doctor, an aha moment, maybe you can help a woman get an earlier diagnosis. And so that's one of the programs that GOCA does. And we do it on a national level with a national organization. And so it's very cathartic for women to get out and talk about it. I know for me it was. So those are the type of things that I would tell women to do. Find a support group. If you don't have family in the area, or, you know, most hospitals have support groups. And I tell women that it's always good to talk to someone about what you're going through. You know, we sometimes want to hold everything in and you know, sometimes it's really, really good to talk about it. So I would tell them to hitch their wagon to an organization that is out there doing things and try to get involved. You know, sometimes ovarian cancer is a very personal disease. A lot of women don't like to talk about below the belt cancers. But, you know, if you're faced with this, that's something you need to explore.
Wow. Well, thank you, ladies, for the well-rounded perspective that you offered us. I think there was something on here for everyone to learn. And so I think we were going to open up for Q&A, and we may have time for 1 or 2 questions. So Victoria, do you have an idea of, do we have any questions submitted?
Yes, absolutely. So we had several questions that were submitted not only during registration, but also here. So one question in particular, I think dovetails nicely with the last topic, is really for advocacy groups, which I know there are several that are on the line. What can advocacy groups be doing to help drive this change? I see one comment in the chat about writing to your member of Congress, sharing your story and how important it is. But Ms. Emory, Ms. Blount, what are some other ideas, or Janice, what are some other ways that advocacy groups can help drive this change?
Well, I'll dive in. On a national level, the Ovarian Cancer Research Alliance, they do advocacy work where, and they have their spring advocacy open now. You can, sign up for virtual, and you can go out and you can actually talk to your members of Congress. The organization will set you up with the person, your congressman, your senator in your area. You can go out and you can tell them your story and hopefully affect change, that way.
Yeah. And I would say, since we're really at the Black Women's Health Imperative, really trying to solve the problem, advocacy is a luxury. It takes time, and to be able to advocate. And so sometimes doctors get the impression that their patients aren't as invested in their health because they're not out there advocating, but they have jobs, they have families. It's hard to do that. But what I want to see are quality measures associated with whether or not patients get the standard of care. Are they being followed up? Are they getting the diagnostic and therapeutic services that they should? And our basic premise is, we think if healthcare system leaders, if providers thought they weren't going to be reimbursed because they weren't providing the standard of care to women of color, they'd figure out a way to provide the standard of care, because I think they want to be reimbursed. So advocacy is hugely important. Please follow Ms. Emory, but also make sure that you're advocating for changes in reimbursement and insurance policies so that we can provide that incentive so that we all can get the standard of care. Ooh.
I think you might be muted.
Janice is on mute. She's talking.
Sorry. I went the whole call without doing that and then did it at the end. So thank you, ladies. Thank you to our panel members so much for showing up and giving us this enlightenment. I'm going to, for everyone in the audience, I'm going to push a quick survey. It's going to pop up on your screen, and it's just going to ask some questions about what you learned tonight. So feel free to answer that. And while you do that, I just want to say to our panel members, I appreciate you being here. I'm walking away enlightened, and I'm walking away understanding the role that I can play in my community and in decreasing late stage diagnosis in Black women. So at this time, I am going to pass this webinar off to Nicole. Nicole, thank you so much for letting us do this tonight, for encouraging it and being willing to drive the change.
Please, thank you all. And I actually just can't believe this is my job, that I get to every day get up and do something that I know is having such a huge impact on the world and on the health of women. And I'm just unbelievably proud to be a part of it. And thank you all so much for sharing your stories. I learned a lot. You asked what we learned. I was keeping notes furiously here. I heard listen to your body, be your own advocate. I heard Black women are more likely to be diagnosed late stage when survival rate is much lower. I heard that lack of quality care, even when women of color have equal insurance, they still have different outcomes, which is, I did not really even think about that. It's amazing. The great unlearning that with the call to action here is to help physicians and women, frankly. I think we often make our decisions about ovarian cancer from a place of fear. And I'd like to be a part of making that very different in the future. So great unlearning. And also I heard 13% of the population, Black women are 13% of the population, but only 3% of clinical trials. And I know, Linda, you guys are doing some really amazing work to encourage a real change there. So, that was That was really powerful as well. And then no such thing as the hard to reach, just the hardly reached. I love that. And last, there's something for all of us, men and women, survivors, advocates, no matter what you do, there's something that all of us can do to help make things change in a much, I mean, I'm sure we've been at it for 20 years at Aspira. You know, we're not giving up, but boy, I'd really like to see the next 20 be a lot different than the last. So, you know, there's a lot of work to be done and we all have a role to play. So I really appreciate the discussion. I do want to give a plug for two things. Tomorrow is March 1st. That's Endometriosis Awareness Month. So another disease below the belt. I like to say Southern Hemisphere diseases, but another thing to be aware of. And then Victoria will be hosting a discussion in May. Right, Victoria. Did I get that right? April, May. Sometime soon, we're going to be hosting a discussion, May, thank you, on surgical menopause, which is something that Kimberly and I both know a lot about. I won't make you come back again, Kimberly, but but this is a really important health issue that's very related to this conversation. So please join us then. And Denise, anything else, or are we? Did you want to wrap up? Okay, great. Denise, Victoria, thanks so much for pulling this together. And thanks so much to all of our panelists.
Thank you.
Thank you, everyone, for joining.
Thank you.
Thank you, Janice.
Thank you.
Thank you, everyone.
Thank you.
Good night.